And then this is kind of our agenda today. I'm going to spend the beginning talking about local anesthetics. Then we're going to talk about local anesthetic systemic toxicity. I'll talk about peripheral nerve blocks in general, indications, contraindications, then I'll kind of go into the specifics. I'll talk about anatomy, but more importantly for you guys, I think the common complications, because each block can kind of have its own complications you should be aware of. And then I have a little section called esoteric or future. There's new things on the horizon. I don't know how much time I'll have. Last time I didn't get into too much, but hopefully I'll talk about exparel. So, does everyone remember this from Bio 101? Nerve cell, axon, dendrite. So that's what we're blocking. We're using our local anesthetics for. You essentially, you have all these transporters in the cell transporting out sodium or potassium, and it creates this membrane potential, kind of like how a battery has different potential. And then when it signals, you get this action potential, which signals the cell pathway. And so essentially, local anesthetics, what you're doing is you're going into the cell, you're going across that membrane bilayer, and you're blocking the sodium transporter from the inside. So that prevents an action potential, so there's no signal. So that's how it works. So local anesthetics, how do they work specifically? The potency of a local anesthetic is determined by how lipid soluble it is. So essentially, how quickly it can get through that membrane layer. The speed of onset, which is different than potency. The speed of onset is related to pKa. Essentially, the drug exists in your body in this equilibrium between an ionized form and a non-ionized form. When you're in the vasculature, you want it to be in a non-ionized, that hydrophobic form. And then when it gets to the cell, you want it to be in that lipophilic form. So the closer the pKa is to the natural pH of the body, the quicker it's going to get to the cell membrane, the quicker it's going to get across. And then you could essentially divide local anesthetics into two general classes, amides of cell, but also floating around in the vasculature. And that also plays a role later in kind of volume of distribution. So if you have a drug you give, how much drug you can give before it becomes an issue. So the three major properties that differentiate local anesthetics are the lipophilic aromatic ring, the hydrophobic tertiary amine, but more importantly, right now, the ester amide linkage, what kind of connects the two. So the amino esters, those are metabolized by the pseudocholinesterase and enzymes in the plasma, so it's sort of independent of how well your liver works. So your body's going to just kind of break it down. And then there's a natural byproduct, PABA, para-aminobenzoic acid, and we'll talk about that in a little bit. And then amino acids are metabolized by the liver. And if you're ever wondering to yourself, how do I know if it's an amino ester or amino amide, the rule of I's, if the drug has two I's in its name, it's amino amide. So if you look at like chlorprocaine only has one I, so you know it's an amino ester. Yeah, lidocaine has two I's, so it's amino amide. So anytime you think like amino amide, think like, is the liver working? Like, is it going to be able to break this down? Because that can play a role in how well a person can handle the local anesthetics. And this is kind of a list. You don't have to memorize this. This won't be on the exam later. But, kind of going over like pKa's, and you can see like the different sites of metabolism. And there's like a recommended maximum dosage, and that's based off like the ideal person that doesn't exist anymore, like 70 kilos. And then, interestingly enough, one of the exceptions to the rule is chlorprocaine. Even though it has a high pKa, we said earlier that like a low pKa means quicker acting. Chlorprocaine has a higher pKa, but it's actually pretty fast onset, and that's because your body is able to break it down so quickly. You could give an incredibly higher dose comparatively to the other local anesthetics that is able to work quicker, and you don't have to worry about getting a toxic reaction because it's broken down almost as fast as it's brought into the body. And we've been using chlorprocaine lately with our spinals. I know Dr. Roberts prefers them. So, have you guys had patients? Well, you guys are pre-op, so you're not seeing too much.
We get the shoulders sometimes, Coast.
So and then you're gonna meet like 1,000 people a day that are saying that they're allergic to local anesthetics. Like, well, why are you allergic? It makes my heart race. I'm gonna go to the dentist. That's epinephrine. So true allergies from local anesthetic agents are extremely rare. If there is an allergic reaction, it's related to the ester local anesthetics that we had talked about earlier, the chloroprocaine. So they produce a PABA. That's a known allergen. So if someone has a true allergy, it's a PABA. So that means that the amides, the amino-amides, are pretty safe for the most part. However, sometimes the amino-amides are in a preservative, and that methylparaben, if someone has an allergen to PABA, they'll probably have an allergy to methylparaben as well. So we have preservative-free local anesthetic. Essentially, in all the blocks we do, we try to do preservative-free.
If someone does have an allergy to the PABA, what, like, is it just like?
It's an allergic reaction, yeah, anaphylaxis.
Okay.
Yeah, true
anaphylaxis.
allergic reaction. Yeah.
Immediately?
I mean, it's kind of related to like anything with allergies, like it's the dose, location, kind of.
It would be something that you would generally see pretty soon. It's not something that you would see like 6 or 12 hours.
No, it's not something you would see 6 or 12 hours. So it'd be like a common
Pretty
allergic reaction, like if someone ate peanuts at school and they're not supposed to, or stung by a bee.
So if they say they have allergic reaction because my heart races, you think not?
Yeah.
It's more the epinephrine.
Yeah. When you ask them, well, when did you have it? And they'll say, oh, at the dentist's office.
Oh.
That's like 99
Okay.
times out of 100. And then so when we talk about local anesthetic toxicity, what we're talking about is that we have high blood levels, and that could be because you did an accidental intravascular injection. If you've noticed, a lot of nerves in the body are really close to the vasculature, so it's pretty easy to inject into the vasculature without even knowing you're in the vasculature. And then, but you don't necessarily have to be in a vessel. If you're injecting near areas that have high uptake of blood, like the intercostal space is pretty famous for having a lot of blood flow, a lot of vasculature, so increased perivascular area, increased uptake. And then if you think, well, what is affected by the local anesthetic, what becomes toxic? It's essentially anything that is dependent on sodium channels, as I had shown earlier, how it works on the nerve cells. So this means the central nervous system. Usually, for most drugs, bupivacaine kind of being the exception, but for most drugs, you'll start to see the central nervous system effects before you see the cardiac effects. And then that's because your heart has sodium channels as well, and that interferes with the kind of the pacemaking function of the heart. So what can we do? Prevention is key. So we're making sure we're using the appropriate volume, concentration of the drugs, kind of understanding the pharmacology of the drugs, which we kind of talked about briefly, and then increased vigilance for early detection of reactions. So, so yeah, so kind of talking about that perivascular area. So you know, intravenous is going to be kind of the rapidest of absorption, intercostal, caudal, the lumbar epidural, and this is kind of important for OB, the brachial plexus, and so subcutaneous being the least. And then other things that kind of affect toxicity is if you put vasoconstrictors in it, like epinephrine's used a lot. So the reason why you're able to get a higher dose before you worry about toxicity with that is because you're constricting the vessels, so you're getting less flow into the vasculature. So less is being taken up into the brain or to the heart. And then this is kind of a list of the maximum dosage. And then, I don't know, are you guys familiar with, because we use ropivacaine and bupivacaine mostly. If you look at the maximum dosage, it's about 3 milligrams per kilogram. But you could kind of round down and say, well, 2.5 milligrams per kilogram. And then when you use in local anesthetic, that's 0.25%, that's 2.5 milligrams a milliliter. So you're essentially saying that, like, whatever the person weighs, that's how much bupivacaine or ropivacaine that you get in milliliters. So if it's 0.25. A lot of times we use 0.5, so then you just cut the person's weight in half. If they're 70 kilos, and you're saying they get 35 milliliters of 0.5 before it reaches the toxic dose. And that becomes important for like more rescue blocks when the surgeon's already injected. And that's important in the PACU handoff when it's like, how much did the surgeon inject? Oh, 20 mils. And then of 0.5, but you have that 90-year-old lady who's kind of frail and weighs 40 kilos. You don't have a lot of room. All right. So the central nervous system toxicity, this is what we see first. This is the initial symptoms. Like, hey, we could be having central nervous system toxicity. There's that classic ringing in the ears, blurred vision, dizziness, tongue paresthesia, and that kind of numbness around the mouth, the circummoral numbness. And then if it's a higher dose, you get this excitatory phenomenon, this nervousness, this restlessness, this agitation, sometimes muscle twitching. And then that's followed by a CNS depression, tonic-clonic seizures, and then followed eventually by cardiopulmonary collapse. So these are things you're going to have to look out for. But if you think like this like restlessness, this nervousness, agitation, and you're doing blocks, you just give someone benzos, maybe they're a little bit older and they shouldn't be having benzos. Is that a paradoxical reaction, or is that just the block that was just placed? So just having like a keen eye, like, and not just writing off like, oh, they're just acting weird because they got a sedative. And then, so local anesthetic causes a dose-dependent depression in the myocardial contractility and exhibits that vasodilating properties. And then I had mentioned a little bit earlier that bupivacaine has the highest risk profile for cardiac toxicity, binds the most strongly to the sodium channels out of all the local anesthetics. So initially you have this like hyperdynamic, hypertension, tachycardia, and then ventricular arrhythmias. It can progress to hypotension. You'll see conduction blocks, bradycardia, or asystole. You'll see then eventually like VTAC, torsades, VFib, or asystole. But luckily the incidence of local anesthetic systemic toxicity from peripheral nerve blocks was 0.4 to 21 per 10,000, so it's pretty low, but it's important risk reduction, detection, and treatment. And so that's why it's important. I know we're doing some blocks in pre-op now, and I know there's like a lot of checklist stuff, but everyone's pretty busy, kind of trying to get to their cases, running around. But I think it's really important to still like, besides the doctor and who's ever pushing the medication, but paying attention to those monitors. What did the EKG look like before we started? What does it look like now? Is this something we're worried about? What's the
Thank you
blood
for
pressure?
saying that, Doc. We appreciate that.
Because that's why we're there. We're not there to fill out checklists.
Yeah, well, it's
No, I don't mean checklists are important. That's not what I'm saying. But sometimes.
no, but like the EKG part of it,
Yeah.
we weren't even doing that before.
Yeah.
So now
Yeah,
we're trying to be aware.
And that's one of the guidelines from Anesthesia Society,
Yeah. Yeah.
American Society of Regional Anesthesia. That's guidelines, ASA guidelines. So that's important. All right. So risk reduction, detection, be vigilant. That's everybody.
Can I ask a
Treatment.
quick
Oh, yeah,
question?
please.
You were talking about the percentage and how much
Yeah.
you can give.
Yeah.
So if this, let's say the surgeon's injected a certain amount and this patient's in the PACU and they're having pain and you want to do a block, but you feel like the surgeon's already injected too much, can you switch to a different drug?
Oh, that's a great question. So, yeah, if, let's say they used bupivacaine and they reached the maximum dose of bupivacaine, that's the maximum dose of local anesthetic for 4 hours. So if they used half the amount of the local anesthetic of bupivacaine in a person, let's say, that means I could use like half the amount of whatever the total dose of ropivacaine is now. So that is important. That's a good question.
And it's for 4 hours?
That's about 4 hours, yeah.
Okay, because I wonder about that. If the doc's injected a ton and then they get to the PACU, they're still having pain,
Yeah.
and we can't do more.
Yeah.
We get into this conundrum. I've only seen it happen once,
Yeah.
but then we couldn't give
Yeah,
a block.
and then sometimes you could still give a little bit. Like sometimes there's room, like ideally this block you'd want to give 20 cc's, but maybe we could get away with 10. And then, the way that maximum dosage is written, the maximum dose is still pretty far away from that toxic dose.
Oh,
So
okay.
you might be able to get away with going a little bit over.
Okay.
But again, it's like, you should look at the patient, like, is this someone who has good liver function? Are they that little old lady that's frail? And what's the site that we're injecting? But yeah, these are good questions. All right, so risk reduction, use the least dose necessary. And then we were talking about identifying patients with increased risk. It's usually, infants, small size patients, advanced age, people with heart failure because their heart's already prone to any kind of insult.
Yeah.
Ischemic heart disease, conduction abnormalities, metabolic disease, liver disease, low plasma protein concentration, because we're talking about protein binding. So if there's less protein to be bound in the body, that means there's more that's going to go to the heart or to the CNS. Acidosis, because that affects that pKa balance. And then medications that inhibit sodium channels. And then consider a test dose with epinephrine. I don't think we use it a lot here, but you don't necessarily have to, but if you're concerned about vascular injection, that would be a good thing to use, where you would inject, paying attention to the EKG, again, if we see like a 20% increase in heart rate, and it's pretty quickly, or like a 20% increase in blood pressure, which, depending on who's doing the block, that could just raise your blood pressure too.
Just a quick question, so why don't we do a test dose? Like upstairs, we do those for epidurals.
Oh,
so why don't we do them with blocks? Why wouldn't we just do a test dose?
Yeah,
Sure.
it's recommended on that's a good question. So with labor epidurals, you're working with a very vascular area.
Right,
that was on the list of being higher up.
Mm-hmm.
And so unlike the blocks where it's kind of that one-time dose, with the epidurals, you're having a continuous infusion.
Okay.
And so if you're essentially in a vein artery, you're just giving it right to it. So it becomes a little bit more important. But there's also people that you would avoid using epinephrine upstairs. Like if someone had like a really bad hypertensive, gestational hypertension or preeclampsia, you might not necessarily want to get on
What would you test
epinephrine.
with then?
You would just use regular lidocaine.
Okay. So two of them.
Yeah.
Positive.
What's that? You do positive?
Yeah.
Yeah, and then it's a very vascular.
One was myself.
Oh,
and
okay.
then,
The heart
it
rate
was
one?
terrible. It was horrible, yeah. And then one was a patient, I almost had a panic attack with her when she had it, because I thought,
Yeah. Usually,
Terrible.
but,
It was the curse, yeah.
well, but that's why
But
we do
it's
the.
scary. It's really
well,
scary.
well, the good news is that's why we do the test dose.
That's why you do, that's why I'm wondering.
And so,
why
it shouldn't
more.
be, because the actual dose we're giving to do the test dose, the amount of local anesthetic is really small. So it shouldn't be, they might get that tinnitus, they might get that ringing in ears. What did you experience? Or was
Whole
this-
lock jaw.
Okay.
I couldn't move, I couldn't, just
Yeah.
tears, I
Yeah.
couldn't talk, I didn't feel like I could breathe.
Yeah,
It was,
And this is when you're having a baby also?
uh-huh.
yeah.
It was scary.
Yeah, no, I
So you're
believe it.
testing more for actual like placement, right?
Yeah.
Not
Into a vein.
medication
So yeah,
reaction.
I didn't go too much into like the neuroaxial stuff in this presentation, but so the test dose, you're making sure you're not in an artery or vein. That's what the epinephrine is for. But also you'll get some of that effects that you experience, that
Yeah,
kind of agitation, that tinnitus.
yeah.
But you're also making sure you're not accidentally in the spinal space, because there's a dosing difference as well. You want to use like 1/10 of the dose for what's in the spinal space, because you could get a really high block if you're pumping all of that local anesthetic into the interthecal space. So test dose just says I'm not in, as far as I know, I'm not in the areas that I don't want to be. I'm not necessarily in the epidural space, but I'm not in bad areas for this epidural infusion. All right, yeah, so we'll do that test dose with epinephrine. Is that on your allergy list, by the way, now?
No.
You know, that's a really good. I have my own EpiPen.
Yeah, so aspirate the syringe.
Yeah.
Aspirating the syringe is important. Incremental injection is important. That's why you see like, give me 5. All right, give me 5, aspirate. And then we talked about be aware of that cumulative dose and the local anesthetic in the perioperative setting. And then we're monitoring the patient, communicate frequently with the patient. And then we're going to consider local anesthetic, systemic toxicity. Can I just spell it last? Can I just
Yeah.
Okay, hold on one second. Last in any patient with like altered mental status, neurological symptoms, any cardiovascular instability, And then sedation might reduce the ability to report these symptoms, so just kind of being aware. And this is, I think, trickier in the PACU setting where they're coming out of anesthesia. And then, so we'll kind of get into the treatment for last, but just a little different for those of you who remember your ACLS. The pharmacology of ACLS or resuscitation with last treatment is a little different. So someone who you're doing ACLS on, normally, you would be giving 1 milligram of epinephrine.
Right.
So part of the problem is that the local anesthetics bound so well as the pacemaker cells of the heart is that the epinephrine is arrhythmogenic in itself. So you want to give enough that it's kind of getting the heart pumping, but you don't want to cause some more arrhythmic issues. So you want to dose it to 1 mic per kilogram. So if you have a 100 kilogram patient, you're going to be giving 100 mics of that as opposed to a milligram. That's a huge dose difference.
Yeah.
The other thing too, sometimes it says you could replace the epinephrine with vasopressin. You don't want to do that either. Bad outcomes have been associated with using vasopressin in LAST. So, and then you don't want to use any calcium channel blockers. You don't want to use any beta blockers. You don't want to use any other local anesthetics because sometimes that's, you might not be in like a cardiac arrest, but you might have some arrhythmic issues going on. You're like, oh, let's give them lidocaine. That was an ACLS years ago.
Yeah.
Let's give them lidocaine. So yeah, avoid that. And so first thing you do, stop injecting the local anesthetic if you're injecting anything. Get help. Consider lipid emulsion therapy at the first sign of a serious last event. What's the serious last event? That's a good question. I think that's kind of becomes a judgment issue, like where is the patient's baseline? And if I were basing this off like what we're seeing like with CNS issues, or are we seeing anything on the monitor that's changing? So, anytime you're considering like, is there CNS changes, like also look at the monitor. Call for a last rescue kit. I don't necessarily think we have like rescue kits here with like rescue check sheets, which is okay. But the ultrasounds that we do our block, we have this on the ultrasounds or in the block artery. And I think you can get these out of the pictures pretty easily as well. So yeah,
No,
intraliquid is 20%.
they're only stocked on the regional carts.
Yeah, I was just
OR.
gonna
Is it
say,
not closer?
I don't think so, because I think the date.
Yeah.
Yeah, it's only on the regional
That was
cart.
the issue, is because it expires, and so they wanted to keep them in pharmacy so that they could use them, but we should check, Amy.
Yeah.
Just came up.
So yeah,
Yeah, that's, yeah.
yeah. It's
I
nice.
will find out about it.
Well, it's nice. It comes in a bag, and we're going to talk about dosage in a second. But essentially, the first bag, leave it wide open, just get it in. Don't worry about calculating anything. Put it up, hook it up, get it in. And then, before we had, because this is relatively new. I'm kind of relatively new to medicine as well, but before we had before my time, before we had the intralipids, you would have to alert the nearest cardiopulmonary bypass team because resuscitation could be a while if the bupivacaine or the local anesthetic was bound so well to the heart. It didn't matter how many times you're pounding on the chest. You had a way to disassociate it from those receptors. So you still might have to consider that even worse lipids. And then always just the ABCs of resuscitation: airway management, 100% oxygen, avoiding any hyper or hypoventilation, because we talked about things that kind of affect the local anesthetic systemic toxicity, and acidosis is one of those. And then advanced airway device if it's needed.
I'm gonna call in.
The other thing, seizures. Benzodiazepines. Use your benzos to help with the seizures. And one of the most common things we have is propofol. And you might think to yourself, why don't I use propofol? It has lipids in it, and it will help increase that seizure threshold. But we're concerned about that cardiopulmonary collapse, and so that puts that cardiopulmonary system at risk, to further have a vascular or cardiac collapse with propofol. So, and then, so treat the hypotension, bradycardia, lipid emulsion. So you bolus this bag over 2 to 3 minutes, and then you infuse 200 to 250 over 15 to 20 minutes. If a patient's still unstable, you bolus 1 to 2 times. You can double the infusion rate. The dose limit is 12 milliliters a kilogram, and so in an adult, that total volume can approach a liter. That's not impossible. And then we don't have a lot of peds patients here, and since we don't have a lot of peds patients, the amount of surgeries that we're doing in pediatric blocks is pretty low, but you just gotta be careful with the dosing with peds, 1.5 milligrams a kilogram over 2 to 3 minutes.
So I think I would draw up 100 cc's and push it, and then do this.
Yeah,
over.
that's what the training says.
That-
for-
right,
I would-
yeah, okay.
I would just get it in. I would just go ahead and
Oh, you would?
just get it in.
The whole thing
Yeah, I mean-
and over the,
Yeah, just get
Okay.
it in. Because the thing is, intralipid is one of those things where this is what was used for like dietitians, nutritions on the floor. It's just a bunch of lipids in the bag. It's not necessarily another.
but I think it takes a while to get in. It's hard to get in. That's why I think they recommend you push it.
Oh, I see.
because
what you're
it's-
saying.
It
As opposed to
it doesn't go as
Because
fast.
Elmi,
Even on a
yeah,
pump,
Alaris pump.
it beeps.
Yeah.
It's
So,
well.
That's a good question.
yeah.
I don't know.
He-
Because I've never had to give it.
Yeah.
Oh, yeah.
Has anyone here had to give it?
I've
before?
given it. Mhm.
Channeling ICU days. is
I know.
supposed to pop open vents. I mean, it's a little bit better in the bag, but that used to be one of the problems because they used to and you see it with propofol in the actual
Mhm.
bottle.
Yeah.
It's getting enough air into the
To replace
space to
it, yeah.
push fast enough. And I think because it is viscous, getting it through on the Alaris pumps when we're not in anesthesia override is more of a challenge, but that's
Yeah.
something that we could change.
Yeah.
too.
Because
Yeah.
it also comes in like in a glass lipid jar, so we would get we can look into that.
Yeah, I'm not sure. I've only seen
Yeah.
it in the bags.
I'm gonna reach out to Ryan, our pharmacist.
And then, continuing monitoring, at least 4 to 6 hours after a cardiovascular event, but they're spending the night in the ICU.
Yeah.
So, and then if it's just a limited CNS event, you need to be monitored at least 2 hours. And then, okay. So, I spent the first 30 minutes talking about local anesthetic systemic toxicity. Now we'll talk about peripheral nerve blocks. We'll get into more specifics, but so just coming off your spine, you have the nerve, and then going down to the kind of that microscopic level, you have your axons and dendrites, and then surrounding that you have the endoneurium, and these all bundle together in fascicle. You have a bunch of fascicles together to make up the nerve, and then these are kind of surrounded by this epineurium, and in between there's fatty tissue, connective tissue vessels. So ideally, when you're doing a peripheral nerve block, what you're doing is you're having the local anesthetic kind of either bathe around the nerve, or if you feel like it's a big enough bundle, you're trying to get into this area so the local anesthetic spreads within this sheath. What you don't want, what you're trying to avoid, is getting into these fascicles, these bundles, because that's where you have nerve injury. Because these local anesthetics, while they're great, are still have a neurotoxicity to them and will cause direct injury to the cell. Sometimes temporary, sometimes permanent. So how do we ensure that we're doing a peripheral nerve block and we're not ending up in a space that we don't want to be? Nysora has this kind of a Venn diagram. So you're using ultrasound, injection pressure monitoring, nerve stimulation, and epinephrine should be here too. It's be like 4 circles. Ultrasound's really revolutionized everything. I think a lot of people, or most people, just use the ultrasound, and then they'll also turn to their nurse or the tech and say, "Hey, is it too much pressure? Like, what's the pressure while I'm injecting?" Studies are saying that's not the best at determining whether you're in a nerve or not. Higher pressure means you're in that fascicle. Low pressure injection means you're in that spot where you can get that spread of the local anesthetic. But they do sell little pressure connectors in between, and it will tell you a PSI reading. And so you don't want to inject anything but a 15 PSI. And then, so this is one of those little gauges, like tire pressure, like nerve pressure. And then this kind of just goes through, you don't have to know this, but just a little flow sheet of using your ultrasound and using your nerve stimulator. So nerve stimulator is great, but it has its drawbacks, especially if someone came in with like a fracture and you don't want to necessarily twitch a muscle. That's going to be hurting the person. And it's also good where, you know, if you're too close to a nerve, you should be able to dial down your milliamps. But if you're still getting like a result at a milliamp, I think it's like less than 3, that means you're probably in the nerve. Although the false positive and false negative rate of that isn't great. It's not 100%. So that's kind of why, like, in an ideal world, we're using everything to kind of make sure we're in the nerve or near the nerve we want to be. So absolute contraindications to nerve block: infection at the site, allergy, a real allergy to local anesthetic, inability to cooperate, patient refusal, relative contraindications, coagulopathies, anti-thrombotic drugs, and then pre-existing neural deficits, trauma. You know, if you have someone like with an ACLS, or maybe they're diabetic neuropathy, you might want to either use less, or you might say, like, I'm worried about like a permanent nerve injury, maybe I won't do anything at all. But blocks have still been used successfully without issues in patients with pre-existing neural deficits. So it's kind of a case-by-case basis.
Well, I'll tell you, the coagulopathy thing is actually a conundrum in short stay, and Marla, maybe you guys can help me with this. But the question is, do we give the sub-Q heparin before or after the block? And I know ASA has changed their stance on it.
So with
Is that a different?
Well, so with neuroaxial anesthesia, those are pretty strict guidelines, but with the blocks, it becomes a little different because
Okay.
the reason we have strict guidelines with anti-thrombotic agents or coagulopathies and blocks is because, you know, let's say you're anticoagulated, you fall, you scrape your shin.
Mm-hmm.
You could put pressure on that, and eventually it will stop. It might take longer.
Sure.
But when I put a needle in someone's spine, there's no way for me to put pressure on there.
Right.
So then, if we're doing a block, let's say like an axillary block or like a femoral block, someplace where we have access, and we could
Then-
put pressure if we're
okay.
worried about bleeding, then we could say, like, yeah, maybe it's okay. Like their INR is like 2. I'm okay
Mm-hmm.
doing a block on a place that the hematoma will be readily apparent, and then
Okay.
I can apply pressure. But that doesn't necessarily mean if they have an INR of like 5 that I'm going to do the block. I mean, they probably shouldn't be having surgery. if they're
Surgery.
on
Right,
five.
well, it's just flipped, and so we were
Mhm.
confused. I mean, it used to be,
Yeah.
we never gave the heparin, and
Mhm.
then a couple years ago, they changed and said, oh, no, it's okay, you can
Mhm.
give the heparin. Now Mikhail told me it's back
That's
to,
right, yeah.
do
They changed
not
in
give the
April.
heparin in April.
Yeah,
Yeah,
in April.
so it's confusing for the nursing staff, I
Yeah.
think, because we just need clear guidelines on what to do.
So, and
Like, we'll do whatever you want to do, but it just needs to be very clear.
Yeah, and I think like it should be in think of them as like 2 separate things. I know it's both
Okay.
anesthetic and needles, but like peripheral nerve block is kind of a separate question than neuroaxial.
Well, that's helpful, even that information is helpful now, so,
So,
okay.
like, so yeah, neuroaxial is strict and peripheral nerve block is a little bit more dependent on.
Well, because I'll tell you, Doc,
Mhm.
I think it's good to know that, because then you'll get a doc that'll say, oh, no, it's okay if it's a peripheral, and the nurse is left, well, why is this doc saying this, and this doc is saying no? But maybe the difference is one is peripheral and the other one is.
Yeah.
So that makes sense.
Yeah,
to me.
and the guidelines also reflect that now too. That's a change.
Okay, appreciate that, that's good info.
So
Can I
the
ask
heparin, I mean, does that apply to all parts of the body? Like, I mean, today I gave heparin to breast lumpectomy patient. And I was like, well, that doesn't matter because it's not abdomen, but it's, systemic effect, and so.
Yeah, I think
And you don't usually do blocks for breast, so.
Yeah, Gray's been asking for them, Dr. Gray.
Oh, really?
Yeah, we've been doing pack blocks.
Oh.
Yeah, I like those blocks too. But no, I think the issue is like why are we giving the heparin to prevent DVTs? But the type of surgery they're having, like, can the surgeon get control of the bleeding? And then if anesthesia is doing something, can anesthesia get control of the bleeding?
The abnormal risk, like, is that not a lab value that you would want to see before you start?
Not necessarily. Like You know, it's like, so like, why is someone coagulopathic is like, do they have like a genetic disorder, it's like a hemophiliac type issue, are they on a medication? And then the other big one is like, is it liver disease? You know? So, or, you know, I guess, has there been a trauma? I would worry about TIC. I mean, those are the ones you consider. So like, you would probably want lab values, but like, someone who like is like, oh, I bruise easily. And, you know, you're like, well, have you ever had a blood transfusion? Or do you bleed at the, you know, there's someone who's like
You look for some medical history that indicated you might have a question before we would actually do labs.
Yeah, it's like when you go to the dentist, you're just bleeding out your teeth, it doesn't stop right away. So yeah, just kind of getting an idea. Yeah, and so, good question. Relative contraindications, yeah, so that's kind of, and then trauma. This is kind of a relative contraindication too, is, you know, someone has like a limb that's been traumatized. You know, are we going to worry about if we block that out? Are we going to tell if they get compartment syndrome later? And so the answer is, the surgeons worry about compartment syndrome. 99 times out of 100, the patient's not going to get the block. However, the literature is kind of unsettled on the issue because supposedly, you know, there's different types of nerve fibers, which I didn't get into a lot, but some of the slower acting nerve fibers that have a lot more kind of bundle around them, so that means the local anesthetic, it's harder to get to them. It's like those slow C fibers. So supposedly those are still activated during compartment syndrome. So even with a good block, if they start having a lot of pain, you could test compartment syndrome. And then again, with compartment syndrome, the only way to definitively know is to put a needle in there and measure the pressure. But, you know, we want to make the surgeons happy, so if they don't want to block, we're not going to do it. And then we talked about side effects with peripheral nerve blocks, last bleeding infection, nerve injury, allergy, and then secondary injury from reduced sensation. You know, if they're not feeling their arm, they're trying to walk to the bathroom, banging up against everything, they could get a secondary injury from that.
So question on that, so we just had a guy who had a bilateral inguinal hernia and was numb both legs from the local. Is that, how is that how is that medicine absorbed? Dr. Peterson was saying it was close to the femoral vein. It's not in the vein though, right? It's just.
No, it's probably the nerve. Yeah, it could be, yeah.
But it was like his legs were both numb.
Yeah,
all the way down.
I mean, because they're injecting pretty liberally, and then you have the femoral nerve that's pretty close by, and hopefully we'll get to that.
They say femoral vein, I'm like, vein, that wouldn't make sense. They said, oh, it probably just like got absorbed by it. I'm like,
well, he
didn't say that, somebody else was, and I was trying to put it.
It might have been the nerve, or because everything's kind of like, even though the sheaths are kind of separate, you can imagine like getting like in that sheath around the vein, and it's spreading down.
Down the leg.
Yeah, getting to the nerve.
Okay, interesting.
Yeah, so upper extremity blocks, brachial plexus. This is like the bane of medical students' existence. I don't know if you've heard of this thing. You guys haven't heard of the brachial plexus?
Well, we've heard of the brachial
Yeah.
plexus.
Yeah,
We didn't know it was the bane of
Oh,
your,
this is
yeah,
like,
we didn't know.
This is like first year, first semester students. Like you have to draw and memorize this thing. Where
Okay.
and it has different divisions, or I should say different makeup depending how far along you are. So it starts off the spine, off the the C5 through, or maybe a little bit of C4, C5 through T1. Those nerves come together and they do roots, trunks, divisions, cores, terminal branches, and it all kind of intermingles. And this is like an ideal. There's anatomical variation, but it all follows like that subclavian artery and the subclavian vein, and then once you get out here, it's actually a vein, and it's kind of contained in that sheath. And yeah, so it's the mnemonic was like Robert Thomas drinks cold beer. And then this one's I don't think I could repeat in public.
Oh, okay, that's good, Doc. Remember we had that discussion earlier. But I'll tell you, we like the upper extremity blocks because we can tell the
Yes.
patients that have them and do not have them. Is that true, girls?
Yeah, you know, a lot of the surgeons here are non-fans of the upper extremity blocks. The lower extremity blocks, I think it makes a little bit more sense when you're like, I want this person to be weight bearing. But like, I haven't met too many patients that are weight bearing on their arms.
No.
Me either. That's good,
But
good.
like I said, we want to make this. We're here to make the surgeons happy.
Yeah.
And then, so we have 4 main upper extremity blocks. We got inner scaling. This is good for shoulder, supraclavicular, infraclavicular, axillary. So, you know, super just being above the clavicle, infra under the clavicle, and then just attacking it at different sites, that brachial plexus. And so it numbs up different parts. And we start with the inner scaling block. This is great for shoulder surgery.
Yeah.
I like this block a lot. You could do a little upper arm surgery, but you're getting like C5 through C7 mostly, so you're missing T1. So that means that that medial aspect of the arm is missed. So this is not a great block if you're doing stuff lower down the arm. Or if for some reason you want to do the inner scaling block, you could supplement with infiltration, or you could get individual nerves. The thing though is if you look at the anatomy, so you got the, you know, the, is it C5, C6, C7. Oh, it's right back here. So here, C5, C6, C7. Brachial plexus coming out here. You're blocking in here between the middle scaling and the anterior scaling. And then if there's this other nerve right here. I don't know if you, it's okay if you guys don't really know what this nerve is, but it's really important. It's called the phrenic nerve.
Yeah.
And that goes to the diaphragm.
We know that because sometimes these patients, they'll get the intrascaling, and if they wait too long or the case before them is delayed, then they start saying, I'm having trouble breathing.
So yeah, no, and that's very important.
Yeah.
The inner scaling will affect the phrenic nerve 10 times out of 10.
Nice.
However,
It's a timing thing though, right?
well, not just the timing thing, but besides giving blocks, I love giving blocks. Knowing how to do blocks is important, but I think one of the most important things is to realize who not to give a block to. Because it's easy to watch like a YouTube video. These are all on YouTube, by the way. You watch a YouTube video and just put a needle somewhere on ultrasound. That's pretty easy, but like knowing who not to give the block to is important. So anyone who you're concerned can't withstand about a 25% reduction in pulmonary function should not get this block. This is mostly like your COPD, oxygen patients, maybe a severe asthmatic who's had changes over time. Maybe it's a combination of things, and this becomes more of a judgment issue. Like, so if they have like COPD, they're on oxygen, I'm not going to want to give that. Or if they're COPD, maybe not on oxygen, but on a lot of medication, I'm not going to want to give that. But let's say they have little COPD, like it's not too bad, or little asthma, but they're also like morbidly obese, and they have obstructive sleep apnea. Can they get the block or not? Maybe. Maybe not, we'll see. I mean, are they staying the night or are they going home? I don't know.
So how do you find that when you're going to do the injection? How do you find the right spot?
Oh, so we use ultrasound. I got an ultrasound here too.
Also, the when you do the blocks in our unit, you have the ultrasound?
Yeah, ultrasound, yeah.
Okay,
Yeah,
I was like-
yeah, I mean, I love this guy.
Okay.
It's my buddy.
Yeah, impossible.
We, I don't know, we can mess around with this, like after or during, I don't know. Who wants to be a model for that? But
Who's got a good neck?
so essentially, with the inner scaling block, you're starting at super clavicular position because it's nice that you see a good landmark, your subclavian artery, and then you see this like grape, like thing that looks like a bunch of grapes around it, and you just follow it up the neck, and then so this is kind of like a slice of the neck here. You have your your anterior scaling muscle here, and you have your median scaling muscle here. IJ carotid is here, so that this is anterior. This is your sternocleidomastoid mastoid, SCM right here. You can kind of see right here, you got these little dots, C5, C6, C7, and then you have your transverse process. You notice how close it is to the transverse process? It's pretty close. And And so yeah, you could you try to inject it in here, and then you have side effects with blocks. We'll talk about side effects with enhanced handling block. So needle trauma, phrenic nerve block we talked about. You could get a blockade because it's really close to neck structures. You're about at C6 level, C6 vertebrae level when you're doing it. So you could get blockade of your vagus system, which would have more of a, you'd have more of a, like a sympathetic response than the parasympathetic won't be working as well. You can get recurrent laryngeal nerve block. You can get cervical sympathetic nerve block. So you get like that, what is that, meiosis, ptosis.
Oh, yeah.
Droplet phase. And doesn't necessarily mean that someone's having a stroke too. So just keep that in mind. And then we talked about that transverse process you're really close to. So like it's happened. I don't think it happens as much now that we have ultrasound, but you could get an epidural intrathecal injection of this medication. And so, you know, you think when you're doing like a lumbar spinal, you know, that medicine sits at the lumbar root level, and it's numbing everything down, but you get a high block here. That's a high spinal. High spinal means none of the phrenic nerves are working. You're going to have a seizure or CNS depression. So yeah, those things you got to be aware of. However, even though you can get that phrenic nerve block, you're pretty far away from the lung up here. You know, it's mostly muscle. So the chance of actually like getting pneumothorax is pretty low. So that's nice. All right, moving on. Supraclavicular block, the spinal of the arm.
I think I had this.
What's that?
I think I had that.
Yeah, this is.
Had shoulder surgery.
Yeah.
Oh.
Oh, for shoulder surgery, you have this one? You didn't have the interscalene one?
I don't think so, because I remember him being down here.
They start down here with the interscalene, and then they move up.
I don't know.
Did they give you a nice medication so you don't remember much of that?
No, I remembered it.
Oh, you did.
Uncomfortable.
Yeah, but
It
this
was a
is.
Kaiser.
Yeah, but this is. Yeah, they could have. You know, you get a little coverage of your shoulder,
But maybe.
but as you see, like in that other picture, you get like more of that
Yeah.
shoulder cape. So this is really good for totals. You could probably do a supraclavicular and like just like total like shoulder arthroscopy.
Yeah, more than that, but
What was that?
I was more than arthroscopy.
That's right. Yeah.
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 Maybe it was something, but I remember going right here. I can't remember if it was above or below.
Yeah, maybe. Yeah, it gets a little shoulder coverage. It's not the necessarily the best block, but you can still do it. And then you know it's like so that kind of medial part of the arm right here is missed by this block, and you could kind of it comes off other nerves, brachial nerves, I believe, and so you could just do like a skin wheel here, and that will actually cover the rest of those nerves.
I've seen it more in elbow surgery, that's right.
The supraclavicular?
Yeah.
Yeah, you do this is good for elbow surgery. And then, so this is kind of where we start, where we see that kind of the brachial plexus, like right as it's going under the clavicle, you have the subclavian artery here. And on ultrasound, you see the subclavian artery, you see the first rib, but you also see pleura right here. It's lung space, not too far away from where this needle's going. But most of the time you got that first rib kind of protecting it. And then you're kind of just injecting around. They call it like the corner pocket shot. You go corner pocket, go above it. And then, yeah, so side effects, complication, pneumothorax. This is a big one with pneumothorax. This block is one of those that like was not in favor until the advent of ultrasound because the risk of pneumothorax was pretty high. You could get a little spread up to the phrenic nerve in this one as well. It's not like a phrenic nerve-free block necessarily.
So is it 30 to 60%?
Well, of the people who get it will have some kind of phrenic nerve
That's pretty high.
issue.
Yeah.
Yeah, and then, you know, kind of similar things about the recurrent laryngeal and cervical sympathetic nerve block, because you're still pretty close. And so, but this is like a volume thing. So if you want to do a supraclavicular block on someone who you might be worried about with COPD, maybe you do a lower block, or maybe you use a higher concentration but a lower volume, so it's not spreading upwards as much. And then infraclavicular, this is under the clavicle. So this is one that you're not going to have as much, or any recurrent laryngeal not recurrent hemorrhage, phrenic nerve issues. So this is a good block work on the arm, but you're not covering the shoulder and upper arm as much because you're kind of lower down. And this is also a good block for continuous catheters. We're not doing a whole lot of continuous catheters here, but you don't have a lot of muscle up here. And so those the continuous nerve block, those catheters, it's really good for them like to sit in the muscle because the muscle kind of just like grips it, so it's not moving in and out. You throw a supraclavicular catheter and nerve block catheter, and that's gonna be coming out pretty soon because it's not like anchored in anything. And it's kind of a deeper block, and you kind of have it in that like parasagittal position underneath the clavicle, and then you just inject around the artery, and then you got your what do you call it, muscle, next muscle area, your pec minor, pec major, yeah, and then so you're close to the lung, so risk for pneumothorax still there, and then axillary block. This one I had a hard time wrapping my head around in residency because when I was first learning about it, because like even though it's called the axillary block because you're in the axilla, but the axillary nerve is not involved at all. So if we write on the axillary block, there's no axillary nerve involved. But that's my hang up, I guess. But yeah, so this is really good for some arm stuff, especially if you're worried about we were talking about like COPD. But this is really great even if you want to lower arm, like below the elbow, maybe a little upstream of the elbow as well. And this way, since the whole arm's not paralyzed, they still get some movement out of it. Because if they're doing like hand surgery or like forearm surgery, it's like some people don't like having their whole entire arm paralyzed. So this is nice for that as well. And then the axillary artery, you have the three nerves. These are the terminal nerve branches now. This is that thing that acronym I couldn't repeat. You have the median nerve, ulnar nerve, radial nerve, and then, but separate from that, you have to get this musculocutaneous nerve, which is between the bicep and the coracobrachialis muscle. So this nerve can be missed, so you might not have like a complete block. You gotta look for this block, this one separately. All right, and then maybe the complication of this, higher risk of local anesthetic systemic toxicity compared to other brachial plexus techniques because it's very vascular. Right there. When you look at the block, it's not just a single artery. There's like a lot of other branches at this point, and so it's easy. You can imagine like being in an artery, not realizing it, or just you're injecting around a space where there's lots of arteries. So perivascular is higher there. All right, lower extremity blocks. We have femoral fascia iliaca, sciatic popliteal, and then the saphenous adductor canal block. All these nerves coming off the lumbar region in the form like a lumbar plexus, and then like the main one is this femoral nerve, and the other one would be the sciatic nerve that we get our lower extremity blocks from. So femoral nerve block, it's great for femur surgery, patella surgery, quadricep tendon surgery, knee surgery, and some analgesia for hip fractures and this is getting like L2 to L4. And then you're kind of doing this at the inguinal ligament area. And so you can see that when you're doing hernia repairs, that's at that inguinal area. And so this nerve, this femoral nerve, sits right next to this femoral artery. So it's easy when someone's blindly injecting everywhere to get a little here, maybe a little bit more than you expected. Yeah, and then this is really important, especially for people helping out set up the blocks. You get a lot of panics sometimes, so it's hard to get to that area. So what's really helpful is to get like inch tape, or 2-inch tape.
That white.
There's like a white one and there's a foam one. So both of those are really good. So if someone's like, oh, can you give me some tape to help pull this back? That's what they're talking about. And then side effects, complications, proximity to artery increases the chance of that intravascular injection. And then people who've had like a lot of like bypasses down there or grafts, you might want to avoid doing this blocking. And then there's this idea that what's called a 3-in-1 block. I think it's fallen out of favor, but you might see this sometimes for people who have like hip fractures. The idea is that besides to get all the nerves that would affect the hip, the pain with like a fractured hip. So it's like femoral, it's a lateral femoral cutaneous, and it's also like the obturator nerve. So there's this idea, if you put a lot of pressure kind of distal to where you're blocking, so I don't know if you've seen someone do that, like push down while they're doing a femoral nerve block, or have someone push down. They're trying to get all that local anesthetic to spread more proximal. Because as we saw in that picture with all those nerves in that lumbar plexus, trying to push it up, and then hopefully it gets those other nerves. Does it work? I don't know. I don't do it. This is my favorite block for hip fractures, though. It's this fascia iliaca block. You're primarily trying to get that lateral femoral cutaneous block. There's like a few different ways to do this block. But so you could, if you go back, there's this layer called fascia iliaca, and what you're trying to do ideally is get in between this plane. You're trying to get this local anesthetic to spread. And you're trying to get this to spread more lateral, and out lateral would be where you have that lateral femoral cutaneous nerve. So it's like a high volume, low concentration block where you're trying to get that nerve. And so you could do that view where you're at the inguinal ligament and you're looking at the femoral nerve and you're trying to block here and get that spread. You could do another view where you got more of a parasagitally, you start laterally, and you see this sartorius muscle and this internal oblique muscle. So this is like closer to the head this way, and this is closer to the feet. And then it sits on top of the iliacus muscle. We call this the bow tie, so we're looking for this like bow tie. You have to use your imagination. This is kind of like astronomy a little bit, or is it astrology? Astrology, when you're constellations.
It looks okay in the left picture, in the right picture it's harder.
Yeah, but so you're looking for the bow tie, and you're just trying to spread all that local anesthetic there. And then there's the other technique. This is like one of the few techniques I'll do blindly sometimes. Like in older patients, sometimes it's hard to see like muscle very well, or if they're really big, it's hard to get good muscle like definition on the ultrasound. And so I'll do this block kind of blindly. If you use like a blunt needle, there's 2 fascia layers. Like you'll have this like tactile sensation of popping through them. It's like called the double pop method. And it's really nice because you can still kind of use ultrasound to assist you. So if I don't see anything, I'll do a double pop, and then I'll put the ultrasound on, and then you'll start seeing that nice spread that lets you know you're in an area, as opposed to like this more like diffuse spread where like nothing's moving apart, nothing's being like hydro dissected. Yeah, so that's fascia iliaca. And then the popliteal block, this is for like below the knee type surgeries, Achilles tendon, ankle surgery. But so the entire lower leg is essentially sciatic nerve, except for this little strip on the medial aspect right here, and that's off of the femoral. It's called a saphenous nerve. So if they're having ankle surgery, you could supplement that with a saphenous nerve block to get that entire ankle, so you don't miss anything. So sometimes like they'll be like, if you don't do that, they'll be like, oh, it really hurts right there, and you did a good block, but they're only focusing on the pain they do have, rightfully so. So it's like, oh, it's 10 out of 10 pain, but just at that one spot. So you can supplement that. And then you're looking at the sciatic nerve, like right as it starts to split into the common cranial nerve, or the tibial nerve. And that's a good place because when kind of going back to that picture where we had all that bundles of fascicles and epineurin, and there was all that connective tissue. This is a good one to get all that stuff in that connective tissue and just really get a good block right as it splits. And then, so with these lower extremity blocks, motor blockade, so like not having a weight bearing patient. And these are all besides the common side effects of peripheral nerve blocks. And then adductor canal block. We were doing these for a while here. I don't know. It's kind of fallen out of favor.
I haven't seen them. I haven't seen really the other ones that much either.
Russ really likes them. I don't know if Russ is coming here.
I haven't seen him for a while. Have you guys?
Yeah,
Very
but
often.
he'll ask them. And then sometimes
Johnson uses the shoulder
Yeah,
blocks,
shoulder
but
block, yeah.
nobody else
Oh,
really.
Wade does shoulder blocks.
Yeah, Way will do them, yeah.
Yeah, and then we're getting called a lot now for the hip fractures.
Yeah, and the hips, yeah.
But yeah, so you're just following that femoral nerve we saw earlier. The further you move down, the more distal you go. There's this like little adductor canal, so the nerve nerve is following the artery, but it becomes more sensory at this point. There's not a lot of motor blockade. So it's nice where you could say I'm doing a block for knee surgery for the total knees, but I'm not affecting the quadriceps. And this helps. This is kind of a frustrating block for a few different reasons, but yeah, you could get good analgesia. Ideally, good analgesia and no motor blockade. But depending on where you go, because there's no exact landmark for where you want to put it, you're kind of like visualizing, kind of see the nerve, and the further distal you go, the more it disappears. The further distal you are, the less motor blockade, less likely they have motor blockade. But the more proximal you go, the more likely you're going to have like going back up to the femoral nerve and you're getting muscle blockade. But so it's really hard to gauge like where the ideal spot is in all patients. So that's what makes it frustrating. The other thing that makes it frustrating is like on ultrasound, it could look really good, but you don't necessarily, the patient wakes up and they're painful. And that could be because the block doesn't, it gets like the anterior portion of the knee, but not necessarily the posterior portion. So it's hard to differentiate, like did the block work or are they having pain from where the block didn't affect it? So it's like, I think the surgeons are getting a little frustrated where they're like, well, we're wasting time for you to do this block and they're still waking up in pain. They might be waking up in pain, but like, and it's hard to tell like, but did we reduce the amount of pain that they would have had? And you could follow that with like opioid consumption, like on average are they consuming less opioids post-operatively, but we're not really, like I don't think it's practical to follow that necessarily.